going to be a great, energizing, informal conversation. No one really knows what we're talking about, so you might get anything up here at this late date in the convening. But this is really a conversation about community engagement. And if you guys don't have a tough enough job of trying to change the business model for healthcare, changing it from illness to wellness, from changing it to into figuring out the social determinants of health, and figuring out how to be externally facing, how to fix the internal apparatus of your institution to be externally facing. Well, you know, the next piece of this difficult enterprise is how to really effectively engage communities. Because you've got to do the internal work. First, you've got to get the mindset. You've got to set the goals. You've got to do the internal work. You've got to figure out how to bring all the pieces together to be in the same esprit de corps. And then you've got to figure out how to deliver on the community engagement part. So this is what we're going to talk about today. And we've got two excellent presenters that have been in this space from different perspectives. We have Dr. Eitan here to my left. Raise your hand. And he's actually Eitan. He's going to tell you about the work of the California Endowment and what they have done, and I understand have made a recommitment to continue to do in terms of investing and building healthy communities. And then we have Pritpal. Pritpal, your last name, Dr.
Tamber.
Pritpal Tamber has actually been doing a considerable amount of research and engagement in this space of community engagement and the question of agency. And I'm going to moderate, except I'm also told that I'm supposed to talk. So I'll try and figure out, and keep time. So I'll try and do and dance and sing. So we're going to have a real show here today. So what we're going to do, this is the format. We will each sort of say 5 minutes of intro about who we are, who we are as entities, and particularly with an emphasis on community engagement. Then we'll have an engaging conversation for about 40 minutes. Then you guys get to work. There will be a couple of questions that we're going to pose to you, and you have to work through at your tables. And then you report back out to us, and then we'll close with some brilliant closing comments. All right, does that work? All right. So let's get started. Should we? So
we have to be engaging and brilliant. This is.
And short.
And short.
He's already said he's blowing out the time.
We only do two of those three.
Right, right. Short, he said, was not in his agenda.
I'm a man, I can't multitask anyway, so there only need to be one. So this way in which the health system essentially sets the agenda is a form of power. And one of the best examples that's just happened of this was in November last year, where the American College of Cardiology, together with the American Heart Association, released new guidelines on high blood pressure. So we have enough long-term data to know that even a small increase in blood pressure is likely to increase your chance of stroke and heart attack. Very, very important long-term data. And so as a result, the level at which you can be diagnosed as having high blood pressure has dropped. And overnight what happened was that 30 million more Americans got classified as being hypertensive than the day before because of the new guidelines. Now that's an extraordinary amount of power. In fact, off the back of that one guideline, 46% of adult Americans are now considered to have high blood pressure. Now that's the health system saying what it thinks people need to worry about. But the thing is, a small increase in your blood pressure, you're probably not going to feel is not having a job, not having access to food, not having access to healthcare. And so the health system can come up and tell you about things that you need to worry about from a biomedical frame, but that isn't the same of what you're going to worry about. Now those social contexts, job, food, safety, access to care, etc., we're increasingly calling the social determinants of health. They've been called that for many years, but that's increasingly hitting the radar in healthcare strategy. And it's good, and it's hitting healthcare strategy so resolutely. The big consultancy firms like KPMG in March this year issued a strategy paper about how do you invest in social services to address the social determinants of health. How does healthcare use its money to fund social services for those things? And it broke down these social contexts into 6 buckets: economic, neighborhood, education, food, social context, by which they mean social networks, and access to care. Sounds good. Places where you should invest. The problem is the people who've actually been studying this stuff for the best part of 4 decades, if not longer, will tell you that those things are really just proximate measures of what really matters. And that actually, when you look at why people lower down the socioeconomic gradient are getting worse health outcomes, there are 3 things and only 3 things that matter, and this is all from the evidence. Power, money, and resources. And that actually the 6 things that I read out were kind of proximate measures to those kinds of things. Now, healthcare, being the kind of technocratic thing that it is, said, oh, let's go on with study power. And actually, we'll hear multiple approximations of this. I'm going to read out a few from a paper. So mastery, self-efficacy, locus of control, learned helplessness, controllability, desire for control, sense of control, and the recent fad of resilience. These are all downstream proximates to the thing that really matters: power, money, and resources. Now, the problem with power is that it's finite. And agency and power could be considered synonyms of each other. And power is finite. And I've already shown how the healthcare system, in this case cardiology, through the guidelines of hypertension, exerts its power. So the question becomes, if power is held by the healthcare system and yet power is required by communities lower down the socioeconomic gradient, how does healthcare show up to give up its power? And that's a really difficult challenge that the healthcare industry is going to have to do, especially as the industry that you all sit in sucks up 18% of GDP. And so that's what my organization's work is. We look at what are the principles of this work, and we help healthcare hold a mirror up to its own behaviors. Because it's easy to go around talking about community engagement, co-creation, etc., etc. But the challenge, I believe, is how does healthcare show up and modify its behavior in order to relinquish its stranglehold on the power over health. Thank you.
Thank you. All right. Ron, tell your story.
I'm going to stay sitting if that's okay. And I'm impressed that Pritpal just called you out in your house. You know, it's a short walk between there and that door, but good luck, buddy. Yeah. So I work at the California Endowment, which is a statewide health foundation. Then I recognize a number of friends in the room from various different iterations of my life, and so hello, friends. I'm not going to call you out in your house much. And you know, one of the things that we have been doing for the past 8 years, the goal is to do it for 10 and then possibly for another 10, as Denise was alluding to, is we've been investing about $1 billion across the state in trying to improve the health status of about 1 million people scattered over 14 low-income communities in the state. And you know, when I was asked to come on to help essentially design and implement this work, one of the big caveats that was really surprising to me was that the goal was to invest $1 billion in improving the health status of Californians, but the one caveat was that we weren't allowed to spend a nickel on health care. So this was, it was intended to be a pure investment in the so-called social determinants of health. And I'm going to get back to it in a second, but one of the things that we have learned in this work, I have simplified to ABC. And I'll tell you what ABC means in a second. But as I was thinking about how to sort of introduce myself to you around this work, I started thinking about, well, what actually first opened my eyes to community engagement as a strategy for improving health. And I realized that my first wife was probably the source of that. And, you know, we're divorced now, and she's wonderful, and we have 2 kids. But she was a community organizer. And she worked with the AFL-CIO for a while, and she worked with various community organizations in the Mission District in San Francisco. And we moved together to Connecticut probably 15 years ago because I wanted to do some postgraduate training at Yale, and she didn't want to leave at all, but she came with me for 5 years to Connecticut, and I spent part of that time in Stamford, Connecticut, as the health director in Stamford, Connecticut. And I worked for the mayor of Stamford, and the mayor is now the governor of Connecticut. And one of the things that he used to ask me on a regular occasion was, who's your wife again? And the reason he would ask me that is because she was frequently organizing picket protests outside of his house. And I tried to evade that question like there's no tomorrow. Oh, she's nobody. You wouldn't know her. She's not really around a lot, you know. He's like, is she? I never told him. But one of the things that she made me do on the weekends was to go to the political protests that they were staging. She was a union organizer, so they were working on the Justice for Janitors campaign. They were working on a campaign to organize healthcare workers in nursing homes in Connecticut. And so she would bring me to these gatherings, and she would ask me to talk a little bit about public health and the social determinants and all that kind of thing. And as I was speaking to people in these audiences, I realized that this is what public health is missing. We're missing some sort of organized capacity to bring people together who are perceived as having no voice into this dialogue about how we use resources. And so I learned about community engagement through essentially passively observing what my ex-wife used to do as a community organizer. So fast forward again, when you go through medical education and training and public health training, one of the things that you learn to do extremely well is to diagnose problems. And we're expert at diagnosing problems, describing problems in journals and having conferences about the problems. What we're not good at is actually coming up with solutions and implementing those solutions. So that frustrates me a lot, which is one of the reasons that I enjoy the work that I do today, because while we may not be perfect, we're trying to iterate as we figure out how to make a difference in communities at the community health level, where so little work is actually done and so little is actually published about how to do the work. So I said ABC. That's what we learned for about $1 billion over the past 8 or so years. And the A stands for agency. And by the way, ABC is what we're investing $1 billion in California. A is for agency or control, as Pritpal described, and it's something that is so fundamental to health, both at the individual level, as Pritpal described, but even more so at the community level, the collective agency of community to essentially participate in decision-making and reprioritize the agenda to shift resources to priorities that are more pressing for them. So we like to say health is political. B is for belonging, which is something that took us a while to understand. But in this country, we have a legacy of apartheid. And in this legacy of apartheid, there has been a lot of injury to people, whole communities that have been injured, excluded, marginalized, and their voice has been essentially squashed. And in order for people to feel like they have a right to participate in decisions that impact their lives, they have to feel that they are seen, that they are heard, that they belong. And there are ways to use narrative to change the story about who we are and what we're trying to achieve to enhance people's sense of belonging. And then finally, C, is the easiest one. We call it changing the odds or changing conditions. And this notion of, rather than asking people to beat the odds, which is what we do in health and healthcare often, is we focus on people's behaviors. And we think if you can change your behaviors, you can beat the odds. What we don't do is look at how the odds are set. What are the conditions that people have to navigate in order to pursue a healthy life, and how those conditions are man-made. And we have an enormous amount of control over changing those conditions. So A for agency, B for belonging, and C for changing the odds.
Great. Thank you. So I'm not a health professional, and it's going to be interesting to compare my language with your language and my ideas with your ideas, see what we come out with. Just to give you a little more of a background, I guess I was trained, I'd be great friends with your wife, all right, ex-wife, sorry.
We're still friends.
We're still friends. I was trained as an activist. I started sort of my early education at a small black college in the South, Fisk University, and my first activist experience was getting smoke bombed at a Memphis rally, the first year commemorating the death of Martin Luther King. And And I said, this is nonviolence, I'm going black power, okay? I think this is because it rained and I had headaches for days, whatever. But, you know, Fisk was also sort of the epicenter of the civil rights movement, and SNCC came out of that. And every class I took, whether it was biology or history, was always something about social justice, social and economic justice and civil rights. So it's part of my DNA in that regard. And my first jobs was organizing food co-op for the Newark Welfare Rights Organization, organizing converting market rate housing to co-op housing in the Bronx. So I guess that's what I know, and it's infused in all the work that I do. So even moving fast forward to my life in Los Angeles, where, you know, my biggest campaign was really fighting the siting of the Lancer project, which was a municipal incinerator slotted for South Los Angeles, spitting distance from schools and residential areas where people lived. And then finally, even on a personal level, organizing my own schools with parents, a parent-driven school. When my first son got failed by the public school system, got trapped into the crack cocaine and is still struggling with that health challenge. So organizing is a personal thing for me, but it's also professional, part of what we do at Emerald Cities Collaborative. Emerald Cities, this third pillar, it's like sustainable, just, and inclusive society. And so how do we green our cities and make them healthier? And then how do we improve with that investment, jobs and economic opportunities? But more importantly, how do you make sure low-income and communities of color that have been on the periphery of the mainstream economy get to play now in this new green economy? So that third pillar we've been building out, and there's a couple of things that I will bring into our conversation, which is well, a project of Emerald Cities is called the Community Learning Project. We are training 5,000 new community organizers in the next 5 years to fight for energy democracy, economic democracy, environmental and climate justice. We are working with community colleges as other anchor institutions, college community partnerships, so that people are actually out there, they're going to be knocking on your doors, and they're going to be calling you all on your justice issues and stands, but also getting community college credit, so they're building careers as organizers. We're working very closely with all of the advocacy groups, whether it's environmental and climate justice or economic justice. One of the things I would have loved for you guys to have seen was, these are the great view, but to actually go to be in Richmond, where we were yesterday, where, you know, one of my last meetings in Richmond, you could look at the Chevron refinery right across the street from a school where we had our training program. You can see the toxins emitting out of that school, and you know the health impacts that are taking place in Richmond as a part of a low-income community that's highly diverse, and where there's, you know, chronic asthma, repeat cases of folks showing up in the emergency room, where there's, you know, acute problems of eye irritations and nosebleeds and all the things that come with ammonia and other toxins that are coming out. These are the sort of community conditions and groups that we work with to sort of change power, change dynamics, change the odds. And lastly, the thing I'll also share is that we've been working with 3 anchor strategies. So all this community organizing, these grassroots organizing, frontline organizing has changed dramatically now that I'm working with anchor institutions. And that level of community engagement has been very different. We've been working with Montefiore Hospital in the Bronx, and with the University of Miami Medical Center in Miami, and then, of course, our partnerships here in this area. So they're all very different community engagement strategies, and love to share some of the pros and cons of all of that as a part of this conversation. ABC, agency. Now for me, I'm going to just be a little controversial. I don't have agency sounds like it's a community, it's an individual personal issue. Issues of efficacy. You said it's efficacy, whether people feel as if they have efficacy to maybe solve their own health conditions or health problems. And you have ABC as well. And it seems, again, so very internally oriented, where you're sort of looking at the individual and as victims, that we have to help them with agency. Mm-hmm. Is that your framing for agency? What is agency? And then why is agency important?
You going? I'm going.
I'll go. So we like power, you know, but when you look into, and Pritpal and I are friends, and he's been very helpful to us.
I deny all that.
We were friends.
They're using the same language. That's why I figured you all been on the phone together or something.
But, you know, we were, at the endowment, we're kind of like, we're not anti-scientific, but there's just a handful of us who've spent too much time in academic institutions, and the rest tell us to shut up a lot because we use words like agency and, you know, all of these sort of highfalutin terms, and I'm one of the worst offenders. So thankfully I have a lot of people who are organizers and, you know, popular educators that work with me who tell me to shut up and speak, you know, in a more relatable fashion, which is good. So we use the term power, but when you go to the literature to try to justify sort of funding power strategies in communities, there's nothing in the scientific literature that talks about power. It talks about agency, it talks about sense of control. So you have to translate essentially what you're doing to sort of fit, or translate what's in the literature to fit what you want to do. So we prefer power. Now people, a lot of people, you know, probably people in this room, you know, they hear power and it's intimidating. It's like power, you know, that sounds political, and, you know, I didn't get into this work to get in a partisan political fight. And so that's taking it too far. We're not talking about partisan politics. We are talking about politics, though. One definition of politics is it's the struggle over the allocation of scarce and precious social goods. And in the case of scarce and precious social goods, you're talking about things like a grocery store or a park in a community. Those are critical health protective resources over which there are essentially struggles, political struggles at decision-making bodies about where to allocate, situate, locate those resources. And many communities that are struggling with health challenges have very little voice at those decision-making tables. So we think power and politics, small p, are absolutely critical. I'll say one other thing, which I probably differ with Pritpal a little bit. We argue that power is not a zero-sum game, and that, you know, somebody doesn't have to lose in order for somebody to win. That there are really kind of efficiencies, democratic efficiencies, in getting as much voice involved in decision-making as possible. We believe in the wisdom of crowds. And our politics have been very inefficient. We've been skewing essentially input towards those with resources and privilege and away from those who actually need these resources even more and oftentimes have more expertise about how we should prioritize the resources. So we do think that the more people participate, the more collective power there is, and in many ways it's unlimited.
So I think we do differ on that. So I think for me, the coining onto agency, so you'll probably tell from my accent that I'm from the UK. So although my company is a Seattle-based non-profit, I still live in London, and we do work in London as well. And when I started this work about 5.5 years ago, one of the people I met was our health minister for England. And I went to talk to him about the things that determine health, which is sort of not healthcare, right? Healthcare contributes about 25% of health outcomes. And I said to him, we know that health is derived from social context. What do we do about that? And he looked at me and said, yeah, that's the social determinants of health. That's what Sir Michael Marmot, you know, the kind of the key researcher in this space, talks about. And he just looked at me and shrugged and said, I can't do anything with that. I run the health system. I have £112 billion. I don't know what to do with this other stuff. And I know stuff that matters to health. I've seen the research, but I don't know what to do with that. And I realized really early on in this work that the challenge isn't the evidence. The evidence is there. The evidence is well described. The challenge is packaging it into something that can be applied into practice. And so when you're trying to do that, then you have to then say, you have to sort of do some kind of equivalent of a kind of a power map. Where is the power over health? The power over health is in healthcare. Whenever people talk about poor outcomes, you hear the kind of quick call of we must invest in more services for this, more services than that. And of course that is very much driven by evidence. And for me, that very recent example of how cardiology has just said we're going to take the drug treatments for 30 million more Americans, that money is going into cardiology, it's not going somewhere else. So for me, there is a kind of a power grab, there is a grab of sort of influence that I think is based on the evidence, based on research, and you have to try to work out how do you package this into an industry that brings them to the table. And for me, that's why I've gotten onto it. In fact, I think, Tony, you were probably the first. I heard you say agency first, made me go and read about it more, and then I see a lot of the sort of synonyms that are in the literature. We've done a fair amount of work looking at the literature between agency and well-being. And you see all these other terms that exist. And it feels to me like what's happened is academia's kind of started staring at its own navel in trying to find the kind of proximate thing that you can actually intervene on and turn it into a lever. But actually it's a sort of deeply more fundamental thing that has to be worked on. So for me it's about saying this stuff is known in the academic literature. We can stare at it forever, but the challenge is implementation. And that to me is why we do what we do. So on the table, some of you will have this document. So we found sort of 12 principles for what it means to try to show up to do community engagement. And what we explicitly try to do is to try to work out from all the people we've interviewed about 100 people over 5 years, to try to work out what does the mirror look like that healthcare can look at to think about its own behaviors. And I think that until that happens, we're still going to see more of this thing of where cardiology gets to suck up more of the resources. And that to me is the challenge, is to try to get healthcare to show up differently.
Great. Well, I have an ABC too. And I use a different literature than the health literature that you gentlemen are in. And so some of you may know it. It's called asset-based community development, or asset-based, for your perspective, community wellness. And so rather than even thinking about individual health, we really evaluate community health. I heard earlier today people always asking the questions of metrics and what are you measuring and how do you show cause and effect. At the end of the day, you talk about the anatomy of the body, and how the body begins to work together or not work together, produces either illness or wellness. Similarly, there's an anatomy of a community and how a community operates, right? So the community economics have to be right. The physical infrastructure of that community, whether your dad walks to the grocery store or not, may have to do with how far he has to walk, okay? And whether there is access to groceries, in his near his home. It also has to do with the social fabric of the community. So for me, when I think about community engagement, when I think about the role of anchor institutions in promoting community wellness, it's really getting you to put on a diagnostic lens about how well is this community functioning. What are the structural impediments that's getting in the way of people living healthy lives? And Tony, I've heard you many times talk about how zip code will determine, your zip code will determine whether or not you're healthy or not. It is not a question of how you are servicing, as a health institution, how you're servicing people. You are not going to service anybody out of poverty, right? But understanding asset-based community development is a lens that says communities have assets. We have been resilient. To your point about resilience, the new fad word, we have been resilient for 100 years, and more. Immigrants that have come over to this country and what they've had to go through to create families and to grow a generation of children. Let's not, talk about the slave conditions. They've been resilient. They have asset, and the reason why you want to engage community is because you'll get better decisions and better outcomes. And there are things that you cannot do that is going to be important for creating community health that you will need the community to do for you.
So
they will take on the big D, the big P.
So can I jump in on that? Because what's quite interesting for me about ABCD as a method is it's been, so first of all, in England there's something like 4 different groups pushing ABCD, and they have a sort of ever so slight nuance to each other that are all kind of fighting each other about their own methodology, which is sort of borderline crazy in such a small country. But not only that, the thing that I find sort of interesting is when the health system has reached out to try to engage ABCD as a methodology, what it's said is that we want to do asset-based, we want to understand the assets of a community in an attempt to reduce diabetes rates. And then what they end up doing is applying their usual 3-to-1 ROI over a 5-year time frame to try to work out, is it worth the investment in these community assets in order to see a reduction in ER attendance? And actually what that does is not only reduce the value of those assets to only the kind of health-related outcomes, but also to some extent infantilizes them, because the reality is it's very hard to show linear causality between that asset and a biomedical outcome. And so actually what happens is that the community sector come along and say, we've got this like framing, this is how we work, ABCD, all of which I completely agree with. But then the health sector comes along and says, well, we've got, I don't know, ER readmission that we care about. We want to value what you're doing on the basis of what we care about. And what actually happens is never the twain. Mm-hmm. And ultimately what you end up with is, and I've seen this happen, it's been happening, it's already started to happen with community organizing, which is relatively recent on my radar, but health systems started to say that strategy didn't work. Well, it may not have worked for diabetes outcomes and ER admissions or readmissions post-discharge, but that doesn't mean that it didn't work for other stuff. And so our lens of analysis in healthcare really reduces the value of these community assets. And I think that's something that we have to be really, really careful about. I don't disagree with that, the value of community assets in the broad value that they create. But healthcare is stuck in a frame of analysis that prevents it from really understanding the value of those things.
So do you have a comment about this?
Yeah, no, I can just say, yeah, I totally agree with that. I mean, it's who sets the agenda matters. That's why this is political. And, Pritpal is precisely right that, healthcare institutions...
Did we get that on record? Did someone record that? Is that...
You didn't let me finish. Pritpal is exactly right for once. That, who sets the agenda, really is he or she who controls essentially the debate. And healthcare and academia and foundations, all of us institutionally based people do this all the time, because we have boards of directors or shareholders or whatever who are demanding this kind of, very narrow accountability. And that's the problem. The problem is that we use our power to control the agenda, and once we set up the question, the answer becomes somewhat inevitable. And so the work here is to essentially let go of the agenda setting a little bit, and that's something that institutions have a hard time doing. And then hold yourself accountable, or, for others to develop policies and practices which force health systems to be held accountable for a much broader agenda. Hold the health system accountable for the obesity rate in the community that it serves. Hold it accountable for the high school graduation rate, the 3rd grade reading rate. If we can align the number of interests that are working on these fundamental drivers of inequity, we have much more hope. But once the agenda is being set by institutional actors, the battle is already lost.
And I would also go further to say that I started my career as an academic publisher, so I trained at the British Medical Journal, so I spent a lot of time looking at research and publishing research. And I think there are some fundamental problems with how we assess diseases that are based on life circumstances. So our lens of analysis in healthcare is very much based on infectious diseases and trauma. Something happened, we can measure it, we'll do something about it. What we are struggling to do is upgrade or evolve our evaluative techniques to understand how to operate in the complex adaptive environments of social environments. So disease is no longer a kind of one-time thing, it's a consequence of multiple things. And we simply don't have the analytical tools for that. There is nerdy stuff out there for that, but the problem is academia hasn't moved on fast enough for there to be an evidence base for people to do something in community health. And so I'll often go to events. I like how you're switching my microphone.
It's time's up.
It's a good technique. Tony, did you slip him a $5 on the way in? So one of the problems that I have is that when I go to events, I quite often hear people like leaders in community health talking about their evidence-based strategies. Well, there's very little evidence of what works in these environments, and people are running around saying evidence-based, evidence-based, evidence-based. You're like, what are you talking about? And if you spend time drilling down into the so-called evidence that they're citing, it's like a tiny project that worked in one very specific environment. It was written up in a certain way to say that X was the reason why it succeeded, not Y and Z, because Y and Z were never understood or measured. And so actually people go around, leaders who get paid very big salaries go around saying evidence-based, etc., etc. They're wrong. And they're scientifically broken. It's like, I find myself amongst physicians thinking, geez, did you really go to medical school? You don't seem to remotely understand the challenge here. And there's this big thing that we're not talking about, which is the epidemiological shift, is that we no longer die from these infectious diseases and trauma at the rate that we used to. It's all lifestyle-related conditions. And that's happening all over the world, even in low-income environments or middle-income countries especially. And we haven't shifted our analysis.
Okay, so let's shift. And I really do think it's important, because I actually do hear you guys saying different things. But anyway, shifting from an epidemiological focus, a clinical focus, a health focus to a community focus. And what should anchor institutions do about communities that are already organized and fighting for its own health and well-being? What do we do about Black Lives Matter? What do we do about the Dreamers? What do we do about the Fight for 15? Does any of this have anything to do with anchors and community engagement?
All of this has a lot to do.
How do they?
And let me say what these institutions should do. They should support the organizing that's happening in these communities.
Yeah.
They should fund the organizing that's happening in these communities.
Want to say that again?
I fund the organizing that's happening in these communities for that reason, because that is what health looks like. That's what community health looks like. It's people organizing to hold systems accountable for equitable outcomes. And that's, some people look at that and they see chaos and they see politics and they're afraid and they want to dive under their desks. I see that and I think, where are the organizers? How can I support them? How can I double down on this? So it's very clear to me that that's what health is. And quite frankly, it's messy. It's messy. Sometimes these things go sideways. And politics is messy. But we don't have a better way of resolving complex and wicked problems other than optimizing democracy.
So I agree with that in direction. But I think that actually, when you think about people in systems with jobs, with kids' school fees, with their own health insurance to pay for, that level of uncertainty, I think, is difficult for people to get behind. And actually, I've spent the last 12, 18 months has been talking to people, to health system leaders, and trying to work out where is what I call the permission space. How much discomfort can they step into? It's not much. And so I agree with that directionally, is that that's the place to go. But I think that actually there's something that healthcare can do way before it gets into funding, although if people here want to start opening their wallets, do feel free to your local organizations. But I think there's something that's actually probably the first step, which is to give credence to that narrative. Because I think at the moment what happens is that the narrative always returns back to high blood pressure. The narrative always turns back to we need to fund more cancer care. You only need to watch I love coming to this country because you kind of see everything that's the issue with healthcare in the adverts between your programs. In fact, I often think your programs are between your adverts on your TV channels. But you can see the sort of pushing of that biomedical message over and over again. That's what health is. That isn't what health is. And so for me, there's something around that giving credence to that narrative that you've just described, Tony, that I think is fundamentally important. I think if you win the narrative, the resources follow. But if you don't win the narrative, the resources are always short term. And the best project, I spent 5 years looking at projects in as many places who will let me listen to them. The best project I saw was in Auckland, New Zealand. Extraordinary work, working with second-generation Pacific Island kids with really high incidence of mental health disorders of multiple forms. And easily the best project. They didn't have the $1 billion. They were very poorly funded, but did extraordinarily great work. New chairperson, it was funded by the health board. New chairperson came in, looked at it and went, what is this crazy community thing we're doing? Let's get rid of that and fund some more, I don't know, antidepressants or something or other. And that was it. And that was because he wasn't in the narrative. He didn't get the narrative. And so they lost their funding and the project disappeared because they hadn't won the narrative challenge. I think if you win that, the rest can follow.
So in my example, that person wouldn't have been able to get away with that because there would have been an organized community that would hold him accountable and he would have been out of a job. So this is my point, and there may be some distinctions between Great Britain and the United States. I mean, we have this racial narrative in this country which has shaped so much of how systems operate and how resources are allocated. And unless you're challenging that narrative, the narrative in California is a different narrative. It's a narrative of inclusion. We look to the past with realism. We see that, apartheid kind of shaped how we allocated resources in the past. We can't go forward in that direction. We look to the future with hope. We recognize that there's all this talent in this state, in our diversity, that has been sidelined. We need to enlist that talent, bring it into the mainstream, organize it, and believe in the wisdom of crowds. We also have to allow people to tell their own story. This is where belonging comes from. You can't have power without a sense of being seen, being valued, being heard. And so the narrative is what shapes that sense of inclusion, that sense that we're all better off when we're all better off. So I do think that it is critical to focus on you all, we all, as institutional actors. Healthcare systems are huge anchors in institutions. You're not going to be offshored for the most part. And so what is your obligation as a neighbor in these communities? And beyond that, what is it that we can make you do by organizing the people that live around you and amongst you and holding you accountable for that higher promise of trying to deliver health in an equitable fashion?
So what I'd like to ask as much as possible, first is, who is the community that you're talking about? I hear you talking about social service agencies, and then I hear me and you talking a little bit more about community organizing entities, their geographic communities, their interest communities, all kinds of communities. And we're going to ask you all later at your tables to really think about who is the community that you, how do you define community and who you currently work with. So one question is really who the community is, but I'd like to even focus in about, well, how do you do it? How do you engage the community? What have you been doing at the California Endowment to actually enact this notion of fixing the social determinants of health without health care? How does it work?
How much time do I have? Okay, so it's actually pretty simple. I don't think it's that complicated. And, I'm a simple-minded guy. I need to know what I'm doing at all moments, and otherwise I get confused and I start to cry. So, this is why I come up with these things like ABC, because I have to know what I'm doing. And it's actually quite easy to do. In fact, if you look at the history of the country, the civil rights movement, women's suffrage, marriage equality, what's going on with Parkland right now, Black Lives Matter, it's all been about people organizing themselves to drive social change. That's how change happens in this country. Even Mothers Against Drunk Driving. It's about organizing. So when we're talking about this shift of paradigm from the dominant biomedical model of sort of institutional actors intervening late in the course of disease in the sort of traditional infectious disease paradigm, shifting that paradigm to one of essentially communities leaning in, or institutions leaning into communities to anticipate where the health of that community is going and trying to figure out in an iterative fashion how to intervene earlier and earlier to be able to essentially blunt the trajectory of adverse disease. That's a major change in paradigm, and it requires a social movement. You're not going to do that with a bunch of pointy-headed academics writing articles. You're going to do that with young people who are organized, recognizing the challenges that are needed and confronting systems.
So you funded them? Is that what you did? What did you do?
We gave them money. We're the biggest funder of community organizing in the United States of America. And the reason for that is because we know that that's what makes change.
And you're looking to them to affect policy? Or what?
Yeah, well, interesting.
Are they coming up with their own plans?
Interestingly enough, we had a model which was basically, okay, policy and systems change is what we need. We need to organize people to build the capacity of communities so that they can actually participate in the political space and change policies, and those policies will change environments. And we're starting to actually kind of rethink some of that. I mean, we think that that's basically right, but that sort of puts policy and systems change at this elevated level as the goal or the end, and we think that actually maybe it's the power that's the end. We want to flip that model a little bit, that policy and systems change are derivative of changing the power dynamics in the community. So we're now doubling and tripling down on power building as not just a means to policy and systems change, but as an end of itself, which is a sort of a permanent shift in the dynamics of power in the state in a more inclusive fashion.
How does community engagement work for you? How should the anchor partners here operationalize this in their institutions?
I mean, that's why we pull that report together, because it's not a report, it's a tool. Because we recognize that actually there are lots of really well-meaning people working in health, and they just want to know, how do we start doing this work? What does it look like tomorrow? So that's why we took the learning that we pulled together over 5 years, we turned it into a tool, and we wanted to start getting people to do that. I think that really for me, it goes back to, I completely agree with Tony, that you've got to raise up the community, have a voice. Power should be the primary outcome that you look for. There are some secondary outcomes down the line, such as systems change, policy change that may happen. But I genuinely think that there is a clear obstacle, and that's the wrong word, but there is something around how healthcare has to show up differently. And that really matters, I think, when we talk about the value of community voice in health. I think that really, really matters. And that's where your leadership comes into it, is like, how do you go into work tomorrow and start making tiny changes? I mean, one of my favorite innovations is actually from South London, where they were trying to get a community mental health nurse to show up in a local community center 1 day a week. And they couldn't do it, even though the hospital wanted to do it, because they knew there were excluded communities that would never turn up to the hospitals because they saw the hospitals as the enemy. And so they knew that would never happen, that the patients would turn up to the hospitals. And they couldn't work out, what they couldn't work out was how they could have a mental health professional operating but not in a clinical environment. Like the hospital is a kind of signed-off environment where it's indemnified, etc., etc. And so they took ages to explain to the lawyers what they needed to do, and in the end it became like a tiny stroke of a pen. And that made a massive difference to being able to have this mental health nurse in this community center 1 day a week. And she's now seeing patients that the system has been well aware that they have no ability to reach them at all. And so there's these kind of tiny innovations that are process level innovations that are your bread and butter, that you deal with on a day-to-day basis. And that stroke of pen is ultimately a sort of an attempt, is ways in which you can actually change how health systems are behaving. And that takes entrepreneurship for you guys as system leaders to start thinking about what does that look like. Again, that's why we designed the tool, was to potentiate your own internal work to come up with those answers for yourself. Just say also in England, I mean, I'm definitely not here to talk about race in America, but I think that the thing that I've learned by going to a few countries in this work is that actually all high-income environments have a version of this. In this country, there's a deep entwining of the race issues with health, but there are versions of it anywhere. And anyone watch Downton Abbey? So in England, it's the class system. So in the US, our work is called Bridging Health and Community. In the UK, it's called beyondsystems.org.uk. And what we're trying to work out is how do systems go back to treat, or find a way to treat people with parity? Because we have the class system playing out where privileged middle classes are treating lower class people who are getting sicker earlier and dying earlier because they're lower down the social gradient. And it is very much a case of people from two different worlds not being able to connect to each other. So we realize the challenge in England is a class struggle. And that's why our systems are failing, and it's not just health system, it's all other systems as well. So there are versions of it that actually play out, and agency and power are exactly the same things, but they have different flavors according to the history of those countries.
Yeah. So I'm very clear that you cannot fix 70% of health problems unless you fix the communities themselves, that you cannot address issues of cancer and diabetes and a lot of the chronic illnesses unless you recognize that many of these low-income communities are toxic communities, and you have to figure out how to fix the environmental infrastructure. When you figure out that most folks are not working at all, working 2 or 3 jobs, and are not getting good nutritious foods, and so really working on the internal operations of the institution is important, but that is to teach the organization how to expose yourself to the external factors and the community factors. And one of the things I'd like to share is we talk about these ladders of participation, Arnstein's 1969 ladders of community participation and community engagement, and so information, consultation, so these lower levels, putting out flyers and having focus groups, sort of the lowest level of community engagement. And there's a workbook that I've provided on the table, not for everyone, there's like a few on each table, that really talks about what each of those tools are good for. The upper end is really community empowerment strategies, from mobilization to actual community organization. And what your goal is going to really determine which, in fact, tool you use to get to your results. And the fact of the matter is, you're going to need it all. You're going to need to have mass, educational opportunities like do not smoke, right? A no smoking campaign. That was effective. It wasn't an organizing campaign. It was a mass media campaign. So what your goal is really going to be dependent on what tools you use. But the enduring work, let me tell you, the enduring work is this sort of new notion of community engagement, which is called building epistemic communities. Epistemic communities. And I shared with you yesterday what that means. It's meaning having health institutions, meaning having people of every social and racial and ethnic group in a community come together and having a shared vision about a shared fate and a shared destiny, and bringing all their assets to the table to create the social cohesion to move that community forward. And so at this point we've been talking about building the internal, capacity of institutions and that of communities. I'm saying the real journey, the true journey, the enduring journey is actually how we bring everyone together, which is the work of ARC that we've been doing here in the East Bay, really building on the base of the California endowments, building healthy communities, but bringing other stakeholders to the table that we've been doing in the Bronx and that we're also doing in Miami. And what is really fun about this is that we have to take learning journeys together to understand communities, because Pritpal, you are absolutely right. These institutions need to come out of themselves and find community. And community needs to come inside the institution and understand how you operate. And we need to understand each other as different worldviews and ethnic groups, and building that becomes really, I think, the core value contribution of what anchors can do in communities. And so we have taken the Montefiore, for example, and the community groups, the Bronx Zoo as anchors. They went to Mondragon and they actually went to see how, talk about learning journeys,
yeah, nice.
How co-ops are formed. Our learning communities here in ARC, we actually are working and going to see urban growers and to understand how food justice works in communities and vice versa. So it's through this really interactive epistemic community structure that I think is going to be the really powerful, enduring work in the long term.
Can I just jump in, because I like that a lot, but what I always worry about is, because I spend a lot of time going into healthcare institutions and feeling people that really want to do the right thing, but it's like, but we can't. Like, the day job gets in the way. And I think there's probably like people in this room right now feeling like, oh, there's stuff here that I want to do, but you're also thinking about the emails in your inbox and whether your kid came home from school or is like running around with the wrong kid in the neighborhood. Like, life just gets in the way, right? So my favorite, by the way, if this is crap, throw it away, right? Because this is what we've learned in 5.5 years.
Mine isn't crap, so don't throw it away.
And
keep this one.
Recycle it. Don't throw it away.
All right, yeah, don't throw it away. But it's got metal on the edge, so I don't know if that's going to work.
Rip it out.
But this is what we've learned so far. But we consider ourselves a learning organization. We always want to hear more. But the one that I think always resonates with people in the healthcare system is Principle 10, which is about building a vehicle within your organization that is somehow devoid of the existing governance frameworks. Because if you have to try to do the work that we're talking about here within existing metrics that you have to hit and existing governance that you have to adhere to, you're never going to get to this work. And so the question becomes is, how can you guys as organizational leaders create some kind of offshoot organization that can operate under different governance? And I think I've seen some really great innovation, but only because that's been in place in the first place. So when I think about, the day jobs that a lot of people, and a lot of my friends back home struggle with, they sort of read my work and say, we'd love to do this, but. So the challenge to the but is to try to construct these vehicles that enable you to embrace the kind of things that you're talking about.
Great. So let's figure out what you guys are doing and what you're thinking about in terms of some of these wild ideas that have been thrown at you, and whether it's digestible, translatable. So I think there's some questions on the table. Did you guys see? Oh, the questions are up on the screen. All right, so what we'd like you to do is just take, what are we talking, 15 minutes, David? 10 minutes. And answer for yourselves or for each other from where you sit. Who do you define as community? Who is your community? Right? Who are you working with right now? Or who do you want to work with? Why are you engaging with them? What's your motivation? And how can you more effectively do so? And then finally, how might you deepen collaboration within your community or within your institution, as Pritpal was saying? How do you fix your institution to be outward facing? All right, so you've got 10 minutes, and then we want someone, we'll do some popcorn responses, a few of it to respond back. Thank you for your attention.
Well, we only
Tell us who you are, or tell me who you are.
Medium Tian, Bay Area Regional Health Inequities Initiative. We only got to the first question and barely that, but we all have different definitions of community related to the programs that we have, but overall, folks that are being challenged because health conditions are difficult, living conditions are difficult, and through multiple efforts, we're trying to get to those communities, low income, minority, with challenges on the ground. One thing that we also didn't get to explicitly discuss, but is the challenge within the institution to make the first move. And that's something that we were all struggling with. I know you emphasize power in the community, but given the societies in which we operate and the disparities within which we function, it's going to take us a while to really get the power there. So I wonder, what are your thoughts on what's the role and responsibility of folks at the top and the leaders, and how the leaders can support some of the efforts that we're doing at the community level. Because if we're just relying on that, it seems like an unfair responsibility to ask our communities to solve the problems if the folks at the top are not engaging.
All right, we're not answering questions now. We'll thank you for that. Any other table? Love to hear a few more ideas. What you're struggling with, what you're thinking about.
So we talked about a number of things. One thing I'm going to add is I think it's not community, it's communities. We should always put plural there because we have so many different folks, inner city, very rural, suburban areas wrought with addiction problems. I mean, we got to be nuanced in each of these areas. Somebody in the front row up here said community engagements should be our goal. I'm just going to disagree with her. Dangerous, because she has a microphone. But community engagement is an important tool. It's not the goal. Health, broad equity. I think engagement has to be one of our most important tools, but it is a tool. I think when we talk about the senior leaders, we have an enlightened 5% that engage in this work. We have the Kaisers and the Dignities. I'm from Gunderson. We've been working on these things for a while. To get the other 95%, I don't know how we're going to get them there. Community engagement can move some things. We can get some movement on health, but to move the healthcare systems to be real partners, I don't know if we're going to get there without changing the payment system. Now that might be our role for our community engagement. Change the payment system. Stop spending all this money on healthcare. But all those CEOs and board members, they believe their job is to balance the books, doing what they get paid for, which is health care, which is, of course, decades out of line. But that's kind of where we're at. Thanks.
Yeah.
One more. I'd like to get just one more, and then we'll wrap. We'll call it a wrap. One more table. Thank you.
Okay, so we had an interesting discussion because we had health departments, community coalitions, an ACO, and a health system. So it was an interesting perspective. And we agree, it's not a community, it's communities. And the different communities can be employees for a large health system and their families. And a community could be if you're in an ACO, capitated lives and risk. And it could be certain communities that experience health disparities and are picked out as kind of hot spots, and the focus, that's the community because that's where you're looking at. The other thing you could look at is not necessarily who you care for, but like a geographic area that you're focusing on. And then you can kind of look and say, well, is our community really more a national community when it looks at policy and policy change to really make, a difference and move things? So I think when you look at community, depending upon who your stakeholder is, it becomes communities. And the other thing that, we basically talked a little bit about was, when you're starting kind of with this engagement, it really is everyone on the same page when you're talking about communities and what your engagement strategy should be. And I agree, engagement is a strategy that gets you to your goal. But the problem that I think people have, and even in our table, we had different definitions of what is health and what is well-being. And depending upon your particular perspective, from an ACO perspective, the health might be, are your gaps in goals and this and that, or if you're in a community-based organization, is it a policy change, et cetera, that brings health and well-being. So I think that's the other piece that on our table was very interesting in perspectives.
Very good. Well, thank you all. I would ask our esteemed panel members to give us some closing remarks.
Well, I'll just speak to, I think, kind of the 95% and something, actually maybe all three of you, which is that I think in terms of markets, and I think if we think about healthcare, I think that when you've got the big healthcare organizations that are making a lot of money in the existing business model, they're not going to change because there's nothing endangering them. And to some extent in my work, we've decided not to show up to their things. And I think at the other extreme, you have tiny rural critical access hospitals with sort of 1 or 2 bed, 3 bed, and they're just keeping the lights on, and largely tax funded, and probably don't have a huge amount to play in that. I'll use the word community in a kind of geographic sense. It feels to me that the sweet spot is, my shorthand for this is where the hospital CEO is still buying his bread from the same bakery as the patients that he serves. So where that's still happening, they still understand what community is. And so they're more likely to show up to do this, find this alternative type of work that we talk about. And some of you may not be in those kinds of organizations. So that is a sort of a struggle, and you should struggle, and this shouldn't be comfortable, and it should wear you down, because that's the nature of system change. But it does feel to me like there is a segment in this market. A rural hospital CEO said to me, probably about 500 million revenue, 2,000 staff, where there's a little bit of R&D capital and a willingness to risk it, and to not necessarily look for an ROI in 3 years, etc., etc. And it's in that space that you're going to find the early adopters, classic adoption curve stuff. That's where you're going to find the early adopters, and it's those people telling the story that are going to create the followership for the 95%. And the role of the leaders is to know when they're in those institutions and they can do that. And that hospital CEO, that rural hospital CEO, said to me, he had a revenue of 103 million. And said, well, I could probably find 50k a year to put into something, but I need a structure to what that something is. So it's when you find someone like that who can throw a bit of R&D capital at this and help shape what this future state looks like, that's really, for me, I think is the challenge. And I don't think you need many of them, but the job of work is to find them and encourage them to spend that money.
Thank you, Pritpal.
So I'm an optimistic person, always have been, hopefully always will be, and I think that there's so much intellect, goodwill, and talent in these institutions, in this room. There are people here with ideas about how to move this forward. And we used to say at the Public Health Department, Alameda County Public Health Department, we used to say, start where people are and enlist them. Enlist them to think about ways in which they can actually take that one step towards community, one step upstream. And when you unleash people, to be free to imagine and to vision and to dream about what they can do from where they are, you get incredible innovation. I started my career, my public health career, working in a health department where I was the health officer, so I was the registrar of all births and deaths, and because I love data, I took all these death certificates and put them into a database and started actually mapping death down to very small geographic areas, and noticed that there were these dramatic life expectancy differences across relatively small places. In the city of Oakland, 22 years of life expectancy difference on average between places in the flatlands and places in the hills. And that's been sort of the central challenge of my career since then, is trying to understand not just what drives that, but how do you undo that? What does it take to get underneath that? And I've toggled back and forth between thinking that the healthcare delivery system had a central role to thinking that I can't take these people anymore. They're so far downstream, they don't care. Let's just make sure they provide good health care and get them out of the way. I'm toggling back because for one reason, in California, we have such incredible partners. We've got Kaiser, we've got Dignity, we've got some small hospital entities that are doing such creative work. I mean, they're inspiring to me, and they're fantastic partners. So I believe that change is afoot, and I believe that California is leading that change. And so to that extent, I remain optimistic, and I really appreciate these kinds of conversations that are taken earnestly and with an idea of solving these problems, not just diagnosing them.
Thank you. So my parting words is to say I feel for you. Community engagement is not easy work. Having done it a long time, having taken arrows out of my back, I've come to define it as one part organizing, one part therapy. Communities that have for decades, lived mistrust, mistreatment, communication. Going through that therapy is going to be important before you also then have to do one part education and having community understand, what does it change, what does it take to actually build a healthy community, and then you can get to one part technical training. So it's a 4-part process. It is a process. It is difficult, but it's not that hard if you really figure out there are different entry points that you can take, all right? That you can actually, if you want to just change knowledge and information about healthy living, if you want to change behaviors, if you want to change policies, if you want to change communities, you can be catalysts at every single level. There are different organizing, different groups that do different things that will help you with that. And you can even look, there's a table over here that even talk about using your employees. In Miami, we used labor unions, 1199, that had a labor management agreement to help do their community health needs assessment, because they did a GIS map and found out that most of their employees lived in their service community, that they were your community. Your community actually are in your hospitals, and they can easily knock on doors, have focus groups with communities to find out where's the pain. So there are different entry points. The workbook that I share with you actually show you how you can use different types of community engagement for different objectives. I've got a few of these available on lessons learned. This is a book for community groups that want to learn how to work with anchors, which you found have been an interesting experience. For example, you all make us sign non-disclosure agreements, which makes it difficult to develop accountability and trust. But anyway, there's ways that this can be done, and I think through this network, through Han, it's an opportunity to learn from each other through these peer exchanges and to bring community into your world, because you will have better decisions and better outcomes. Thank you very much. Thanks, guys. Look, I think I want to bring a whole panel.
Wow. Can we give him another round of applause? It's not easy to go last, and I've got to say, though, everyone was sitting here riveted to what all of you were saying. So thank you again to Denise for an excellent job of moderating, as well as Pritpal and Tony for coming out and sharing your perspectives. So I stand between you and the reception, which has drinks as well as food. So I'm just going to quickly close us out, give you a very quick preview of what the network is looking towards over the next 6 to 12 months. At our fall convening, which we talked about earlier, which will be in Richmond, Virginia, I'm excited to say that we'll have the WHO coming. They've been doing work around anchors in Europe, and we've been talking with them, and we'll hear what their research is showing around engaging health systems as anchors. Moving forward, our work around building the evidence base and starting the pilot metrics, as well as finalizing plans for Policy Day 2019 around the issue of affordable housing. So really incredible milestones in store for the next 6 months. And then, while we have that date, December 4th to 6th, so please save it, and we hope you all can join us there. We're already looking forward to spring 2019, which will be in Cleveland, Ohio. And can I see a hand raised from Metro Health and Cleveland Clinic? There we go, our wonderful co-sponsors for that event. And so we're very excited to bring the network there as well. And we're having perhaps some conversations with Modern Healthcare about partnering with us on that as well. So we think we can have a chance to really elevate the voice of the network beyond the 5%, so that we can reach the other 95. And the last thing I'll just share is that the Democracy Collaborative is using the model of Healthcare Anchor Network to see how we can expand it to other sectors. So we've gotten off the ground in the last month a higher ed Anchor collaborative model around the country in partnership with CUMU, which is a coalition of urban metropolitan universities. We have 30 universities that are part of that Anchor dashboard collaborative. And we will be bringing together Anchor collaboratives, so those entities that are bringing you and other partners to the table in cities across the country, to Baltimore in June in partnership with the Baltimore Fed and any Casey Foundation to help figure out. And we're looking at folks coming from almost 30 cities across the country that have the beginning of this infrastructure to keep the conversation going at the local level. So we're really excited about the potential for not only having a network with healthcare, but how that expands to these other sectors, and then how the conversation comes back together with all of your partners. I'm too far away. So that's all I have. But I think we have a lot coming up in the next 6 to 12 months. Thank you all for coming. That can't happen without each one of you taking part in these conversations. So I'm going to see if anyone wants to put their voice into the room before we close with any last-minute reflections. It's only been 2 days. It might have felt like longer. But we got a lot done in 2 days.
I was so well to you, because I mentioned like 3-4 years ago you were talking about this. I was like, who's this teenager? What the hell is he going on about?
Pritpal, I haven't, paid for your travel yet.
With your paper round. But well done to Dave. I mean, look, seriously, you and your team, well done.
Yes. Well done to the team, right? It's been a team effort. You've met the incredible staff that is supporting this effort as the backbone. And so let's give them actually another round of applause to the full staff. So with that...
Dave, I just want to add something. So when Dave opened the meeting yesterday morning, he said something that might have floated across the room and maybe touched some people, but he said, we support this work, but you're leading it. So that this is participant powered, this is member powered. Now maybe we've heard some things from this panel that will challenge that. Maybe we should say you're leading it for now, and the communities will be leading it in the future. But we really appreciate people coming, giving your time, as we say, acting from generosity, because if we all just did our jobs, this work wouldn't get done, right? So thank you so much for contributing all your intelligence over the past 2 days to advance our work together.